Good afternoon, everybody. I'm going to take a little journey today with this full arch case analysis protocol. This is something that we have been doing now almost since the time we've been working with these cases, and it's something that evolved through issues with bites that we had early on. And basically, the whole emphasis on this protocol is to treat more than just the patient's teeth. We kind of look at it as treating the full person, and as far as their smile and their looks, and how we can change their facial features. Some doctors cooperate with that, most do, some don't, and that's okay. Basically, as long as they sign off on what we've questioned and ask us to continue, that's what we do. So we'll get started here. The presentation is designed to give the best path for optimum results of full arch reconstruction. So everything that you see in this presentation should be done before the case is sent in to make guides. Because quite often, I would say 80% of the time, we have to address the issues that you're going to see here to get the case to a point where it's ready to plan and give the patient a good result. So what you're going to need from us is very simple, or what you're going to need from the doctor is very simple. Master models or impressions capturing all borders and anatomy adequate for full denture construction. And that sentence is if the doctors want spare dentures, backup dentures in case they can't load the case. If they don't want backup dentures, then we don't need all the anatomy. We need teeth, we need a decent amount of anatomy. We don't necessarily need all the borders. It's nice to have some of the palate for the pin guides and all to sit on. We need confirmed bites and vertical dimension information, and we need photos. And the crux of this is going to be built around the second bullet point there, the confirmed bites and vertical dimension information. So we suggest to our customers for the first appointment, meet with patients to determine the treatment plan, take models and records, and take the photo series. So that's first appointment when a patient is interested in this, and they might decide at that appointment that yes, I want to do it. So the doctors take models and records and photos. If they decide they don't want to do it, obviously models and records and photos aren't necessary. So the second appointment, which in my opinion for the doctors is the most important appointment in this whole process, is to perform facial analysis to determine vertical dimension. If the vertical dimension is such that the bite needs opening, more than 3 millimeters, then we suggest that the patient have an orthotic to wear to confirm the VDO and CENTRIC. The doctor has to provide us with CENTRIC, an aesthetic analysis, and to fill out what we've developed as an aesthetic and functional checklist. This checklist will cover all the above questions of the first 3 bullet points that you see there. It's on the lab's website, and it can be found easily. So as a asterisk to this, if orthotic therapy is indicated, we suggest that this process be done before we progress with the case. In other words, if the bite has to be open 3 millimeters or more, that's a significant amount, and some people can tolerate it, some people can't. Now, what you will experience most of the time is that doctors don't want to let their patients wear them very long because the patient's anxious for surgery, and they want to get the case moving. So they might wear it long enough to, maybe a week or however long the doctor sees fit, or they just might equilibrate it right there when they see the patient the first time, and say, this is going to work and we should continue with the case. So their philosophy on that is, and I've heard them say it, which I guess makes some sense and could be construed as correct. You know, they'll say, we're going to use the surgical prosthesis as the orthotic, and we'll do all the changes in that before we make the final. So in essence, they are wearing the orthotic for 4 months, but it may require, you know, adjustment that would not have to be done if they did wear an orthotic. So it's up to them. You know, whatever they want to do is okay. Okay, so this is the aesthetic and functional checklist for full arch. And at the second appointment, the doctor should fill this out. And from just start at number 1 and go all the way down to number 10. And if he answers all those questions, then we should have the information we need to continue with this case. So, bites, vertical dimension, and aesthetics. This magic bite button is something I wish existed, because the reason I put that in here is not trying to be funny, but I don't know what your experiences are, but for some reason, digital dentistry has caused doctors to not do the dental steps necessary to get us to a full arch rehabilitation case when we work in the digital world. You know, as you'll see coming up, we'll get cases in here that have 1 centric stop, that have 2 centric stops, that have no posterior teeth, just anterior teeth, and we're asked to make single arch or double arch, full arch restorations to put into the time of surgery and have the bite correct. Well, we just can't guarantee that. So those are the kind of things we address here, and the kind of things that we get that don't have the bites necessary for us to know that this case is going to work. This is, you know, at surgery, you're going to have a reasonable occlusion. And we don't guarantee occlusion on cases like that, or we can't tell them that we're going to have an occlusion that works until they give us all these confirmed bites, vertical dimension records. So we kind of disclaim it at that point if they want to continue, and we're happy to continue as long as they say that they feel good about the bite they've sent us. Okay, so confirmed bites and aesthetics are bites with positive centric stops, or bites that the doctor has verified with wax try-ins, printed try-ins, or orthotics to confirm vertical dimension and centric. And, you know, the doctor obviously must present us with information regarding tooth position, shade, or changes or improvements to the patient's existing dentition. Now, positive centric stops in our terminology, at least when we talk about this amongst ourselves, are models that you can handhold together, and there's no doubt as to how they interdigitate together. That doesn't mean that there is not a CRCO issue involved, but at least we can hand mount those, and that's where we can start working. So on those particular cases, if we have positive centric stops, we continue with the case. So now I'll show you some of the things that we receive here that that we question, that we can't sometimes develop good planes of occlusion or good aesthetics, or have enough bone for implants, or have enough restorative space because of the bites that we receive. So what you see on the picture on the left is what we do with our bites when we get them, and what we suggest other people to do at the same time is doctors take a bite scan, and this picture on the left is what is in our STL viewer, and we print that and we fuse it together with little sprues so that we capture that bite that they sent us. And from that, we print separate models, and we transfer that bite to these models so we can mount them. And from that mounting, we measure, we have some measurements we use, and I'll show you what we use to determine VDO. Now these cases, according to all the literature that I've read, and doctors that I've talked to, should not be built into deep class 2 overbites or overjets, especially the deep class 2 bites. That's contraindicated for this kind of work. The occlusal scheme does not lend itself to success simply because of overbites and interferences during occlusion that can be detrimental to the implants. So the bite you see on the left, the white models, is different than the bite you see on the right. The bite on the right is the proposed vertical dimension that we want to show the doctor. And to do that, this is on an articulator. We show the doctor the bite they sent us, the closed bite. We open it to the proposed position, and we send them 3 pictures, one from the facial and one from the right and left side, to show them what the occlusion looks like. And we also look at photographs to see what the patient looks like, where their anterior teeth are. Can we open this bite without having to move the incisal edge position if the incisal edge position in their photographs looks good? So things like that we get concerned with that ultimately lead to a better case. So the photographs we need, there's not a bunch. We have about 7 that should be minimum photographs, the amount of photographs we need. And the photos that we need for aesthetic information are not to be retracted. In other words, full face smile photos, above the hair, below the chin, patient looking straight ahead with no cant to their head, and the eyes are level to the floor. And the retracted pictures we need are of the patient's bite in occlusion from both right and left side. Okay. All right. So the pictures that we need here is repose, which shows the incisal edge. It shows the incisal edges of the teeth at rest. A natural smile, which everybody has, and an exaggerated smile. And as you'll see later on here in the presentation, the exaggerated smile is, or should be, a gigantic red flag if the patient in their exaggerated smile shows a lot of gums, because those are the cases where a transition line issue could happen. And I think everybody here should probably understand what a transition line is, or a problem with a transition lines, but I have a picture of one to show you. We have developed a formula that addresses the gummy smile, and so far has worked very nicely with getting these cases completed without having transition line issues. And the last photograph that we use is a profile picture with the teeth in occlusion, with the hair pulled behind the ear, and so that we could take a Frankfurt mandibular plane angle measurement. And this happens to be, all of these are how we do our facial analysis, but this happens to be one of the photographs, or one of the tools we use to help determine if vertical dimension needs to be addressed or not. Now, we don't, we're not dogmatic about any of this with the doctors. We recognize cases that could have their vertical opened. We make the doctor aware of it with scientific measurements and photographs, and they ultimately decide what to do. If they don't want to open the vertical, they could run into plane of occlusion problems. They could run into situations where there's not enough restorative space, or we have to use shorter implants, different things that could happen during planning that would prevent the optimum result for a patient. And this one we don't use a lot, but when it's available to us, we do. And it's just the rule of 3. where from the bottom of the chin to the bottom of the nose is a measurement, and from the nose to the brows is a measurement, and from the brows to the hairline is a measurement, and they should all be relatively equal. Usually the one that's off is the bottom one from the chin to the nose, which indicates VDO could be an issue. So this works for everybody but people who are bald. So we don't use it for bald people. Hope nobody out there is bald, but that's okay. So the pictures that we need for the bite are a face forward, as you see on the left with the teeth in occlusion, retracted, and the left and right buccal views. And we should get pictures with these cases, or you should get pictures with these cases that show that, so that you can compare their digital bite scans to what you know, they send us, so that when we mount them, they can be mounted according to what you see in these photos. And if they are different, if they don't match, that's when, you know, we would call the doctor and tell them that we have this issue, and the doctor will either send us another bite or have us hand hold the models if there's enough centric stops, and otherwise we would have to, you know, again, he would have to provide us with another bite. Or he might say, go ahead with it, I'll do the adjustments chair side. So all three of those things are you know, is a solution to some degree. So vertical dimension analysis, and we find that this is, of all the issues that we have, the attention to vertical dimension on these kind of cases, the one that is not addressed enough, or is the least part of this work that is ignored or just not thought about. Let's put it that way. So we have suggestions for this. You know, we suggest that cases without positive centric stops or deep class 2 occlusions have bite rims made for tooth triad. Okay, with openings of 3 millimeters or more, we suggest an orthotic be made to verify centric and vertical dimension before any of the guided smile process begins. Bites are confirmed and resolved with an orthotic, can be scanned with the orthotic in place to capture the correct bite, and the digital data sent to the lab, or physical models can be sent along with the orthotic for us to scan into the software. So this seems to be the biggest issue we have with these cases, especially double arches, but you know, even on single arches we have it. The second biggest issue we have with these cases are bites that are not correct when they come in. So we have, like I said earlier, we have about an 80% rate of cases that come in where we're lacking some sort of information that we have to get. So that's why I say the facial analysis needs to be done before anything is sent to us, and done properly, so that when we get the case, we can continue on with it and not have to stop for this or that, which just, we would think, add more length to the finish time of the case, but usually it doesn't, because doctors don't necessarily want to change surgical times for various reasons, and we start running out of time and still have to get the case done. So, so the tools we use to analyze VDO to help you determine if the VDO needs to be considered are the following. I don't know if any of you have studied neuromuscular dentistry, but I learned this at LVI. And it's called a Shimbashi measurement. And this is the one that we use most often to help us, give us a clue that the vertical dimension might need addressed. So, you know, and I have pictures of this. So with teeth in occlusion, the measurement is from the CEJ of one of the upper centrals to the CEJ of an opposing lower central. The distance of that measurement that is normal, and meaning that most people, this dimension is between 17 to 21 millimeters. So when this measurement is less than 17, the path of closure of the teeth causes unnecessary muscle activity, puts the jaw and muscles in conflict and create jaw pain. And the only way to correct this is with an orthotic, test the bite, and come up with something that is more comfortable for the patient, or is comfortable for the patient and helps get rid of that problem. Now, I've also read in literature that when we get into these closed bite situations, that's where the destructive occlusion is at its worst, meaning that when it comes to implants, that if the case isn't engineered properly, there is a more potential to lose implants in this situation than when the measurements or the vertical dimension is normal. So if you're forced to work with something below that measurement, then you might want to ask your doctor if he wants to put more implants in just to help protect this from the kind of destructive activity that occurs. Okay, the other measurements that this is a Shimbashi here that you see, and if you follow my mouse, on the right, this is normal. Okay, so we have an 18.5 millimeter measurement from CEJ of the lower, CEJ of the upper. The middle is less than normal, it's 16, and that's a borderline measurement. And the way we determine whether we should use that is we look at the photographs and the patient smiling and some of their facial features, and we determine that, this is fine, tooth display is good. We would continue on with this measurement or suggest an opening that allows the patient's facial features to look better, meaning that, they have this collapsed look to their face. They have the crow lines coming from the commissures or the corners of their mouth. They have a frown on their face from the smile. And I have some more pictures to show you what we kind of look for here. And the picture on the far left here is just totally closed down, and the incisal edges are even with the upper is even with the gingival margins of the lower. So the only thing I would caution you on here is that if the patient's bite looks like this picture in the left, make sure that some of this overclosure or what looks like overclosure isn't what's called altered passive eruption, meaning that the teeth erode and the bone grows and the teeth move up into the empty space, meaning that the vertical dimension is still not collapsed. And I would use this fold-to-fold measurement here to help collaborate with the Shimbashi to make sure that they both agree, or if one doesn't agree with the other, then you really have to look a little closer at this case and try to determine whether to work with what the doctor gives and continue with the case. But all of this is done in collaboration with the doctor. All these things that I discuss, we discuss with the dentist also. Okay. So there's a second measurement, the fold-to-fold measurement, and depending upon the models you get, you can use this. And from the buccal fold of the upper to the buccal fold of the lower in the lateral positions, patients are 35 to 38 millimeters is normal. And you would be surprised how often a Shimbashi measurement and this measurement agree with one another, whether it's too closed or normal. They seem to really agree or disagree with each other, meaning that here's two indicators that say that the doctor should consider looking at VDO to see if the patient needs a change. Okay. And this Frankfurt horizontal, this is probably the one we use the least because this is the one we don't get pictures on that are quite good, and we never know when the patient's in a profile view whether their teeth are in occlusion or not. But we can use this measurement with the positions of the lines where I showed you, and if this angle here between the two lines, this arc is less than 20 degrees, then that's just another piece of information that we can use to collaborate with Shimbashi and fold-to-fold to say that, yes, this VDO might not be correct. Okay. And the rule of thirds, easy. We just take the measurements. And if the bite is really collapsed, like you saw one of the bites when I showed you early on, this measurement, the bottom measurement, is the one that will not coincide with the top two measurements. So that's a tool also. And it sounds like a lot of work. It doesn't take very long, but at least if you call the doctors and tell them, give them this information, it's science. They, you know, it's something that they can't dispute. And, you know, that explanation, when you use science, is really the thing that convinces them that, you know, maybe we should look at this and maybe we should make some changes, and should be pretty successful with those kind of, with that kind of information, on at least getting the doctor to double check his information. So this is what we use along with our measurements to help give us an inclination or a clue as to, is this patient, do they need vertical dimension help? But all these pictures show, here's attrition on the bottom left that allows the bite to collapse. This is this bottom middle picture. You can see the lower incisors are touching the worn stubs of the uppers. On the bottom right, you can't even see the lower anterior teeth. Pictures, photographs show this area of the mouth. It shows the frown here. You have kind of a C configuration if you drew a line from the chin up through the nose. This patient looks collapsed. His cheeks or jowls are too far closed, causing this line at the commissures of the corners of the mouth. Same thing here. We got the sunken in cheeks. So those are things that also are an indicator too that maybe we can help somebody. And when I say, you know, when we look at all this stuff, it's not that we couldn't make a case on what they send sometimes. It's just that with just a little more effort, we can really make a case for a patient that takes, in appearance, takes some years off of their look. They can function better, you know, they feel better. You know, they pay a lot of money for the case in the first place. So you're just treating the whole patient when you go through these exercises. So here's some, this is lack of centric stops. We were asked to make a double arch case on these two pictures right here. From this bite to go to surgery with an upper and lower guided smile with prosthetics, and we just stopped it. We didn't. You know, we sent doctors a try-in, something they could confirm the bite with in vertical dimension. They did that. We did open the vertical. You see a deep class 2 here. And we continued with the case, and it was successful. This picture on the left is just the same thing. You know, this one shows that there's no centric stops in the posterior. So even though you have anterior centric stops, if they're not confirmable, you know, the patient can bite and overclose in the posterior and go to a surgery with a bite that when the doctor puts it in, the posterior is hit and the anterior is open 5 millimeters. So those are the things that's the reason we address these cases with questions to the customer. Just another example. This bite is so closed. It's incredible. Can't see the anterior teeth. Here's the amount of overbite, overjet that is on the case. This is a picture of the proposed vertical dimension opening that we send the doctor. And along with that, we also sent a try-in of teeth. We were able to, so that they could confirm the vertical and centric at the same time. Okay, here's another example. This one we made an orthotic on. There was one centric stop here, a couple on the right side. As you can see in this picture, there's not very many. So we made an orthotic, the patient wore it. The doctor made sure the patient was comfortable, got VDO and centric correct, sent that back and continued with the case. But this was all done before any other information came to us from them. And the bite scans were taken with the orthotic in place so that the bite that the orthotic resulted in was transferred to the software, and the bite at the surgical appointment with the prosthetics were successful. Just another example where we would suggest an orthotic here. That's just a tremendous bite opening, but you can see what we started with here. And this is not an altered passive eruption. This is just, these teeth are just beat up. Just a terrible attrition. The bite has collapsed down. And on this case, we made an appliance that fit over these teeth into occlusion with the upper of that vertical, and the doctor confirmed the bite and VDO with that. And when we got that back, we continued with the case. Another example, deep class 2. Here's where we started. Here's the patient. And you can see he looks a little bit overclosed. And again, just pictures of where we propose to open the bite to so that they can see it and agree with it, or give us feedback on how they want us to change it or close it or whatever. And so, you know, and sometimes when we make these Shimbashi measurements, you know, this might be 16 or 15, but when I open this on the articulator, I try to keep the canines into a position where they could have canine guidance, shallow canine guidance. And I watch the plane of occlusion of the opposing arch too, to see if we can get the guidance we need plus a decent plane of occlusion, and, you know, not resort to huge bite opening. So that's something that has to be used with discretion, but that's part of the analysis of these kind of cases. So this is just a result of an reestablished VDO that we made on a patient. You can see here how her lips were. I mean, everything's different. The patient just looks a lot better. Okay. So how can you send orthotic information? How can a doctor send orthotic information to you so that you can continue with the case? They can do it digitally or analog. And with the analog type, you would send the adjusted orthotic with upper and lower models in, and you guys would scan that into the software with the orthotic in place. And then you would merge another model in there without the orthotic, so we could, you know, build the setup and whatnot into that information. Digitally, you just basically need to scan the patient with this orthotic in place, in position in the mouth. And, you know, when you do it the digital way, the patient can keep the orthotic and wear it if the doctor thinks it's, you know, good and the patient's comfortable with it. And we can work off the digital bite scan of the orthotic. So those are the two ways we can get that information. As I alluded to earlier, this is maxillary hyperplasia, gummy smile, whatever term that, you know, people use for it. This kind of smile is where we would stop if the doctor did not give the information we need and send them pictures and ask them to do some measurements for us. And the measurements are here. So and this is why the exaggerated smile picture is necessary just for this kind of a case. We would have the patient smile in an exaggerated smile and measure from the high lip line to the incisal edge of a central and give us that measurement. And this is the transition line problem that we try to avoid. And on these kind of cases, that's a reality that could happen. So sometimes on these cases, you have a measurement that doesn't allow you to do a hybrid simply because you might run out of room for implants because of the bone that you'd have to take away. And then that case turns into a crown and bridge case that can be done instead of making a complete, you know, fixed hybrid kind of a case. Okay. So here's the formula. And we developed this to help us with all of the, you know, with these kinds of cases. So basically from the measurement that you get from the incisal edge to high lip line measurement, we add 4 millimeters to that. And where that measurement ends up, which is right at where the top of the implant should be, you know, if we need 15 millimeters of restorative space. So if the measurement they gave us was 10, then we would put the top of the implant in the bone at a measurement from the incisal edge. We would make that 14 millimeters. So the measurement's 10, we had 4, that's 14, that's where the top of the implant would go. Okay, so we also need to have at least 15 millimeters of restorative space. So once we get that measurement, the incisal edge measurement, the high lip line measurement, we need to have 15 millimeters from the implant to, and this orange outline you see is the prosthetic, the setup of teeth, the hybrid itself. We need 15 millimeters to wherever a screw hole would emerge from the prosthetic, from the prosthesis itself. So if by using this measurement, we would only measure 12 up to here, that means that the implant needs to be moved down apically to create the 15 millimeters of space. So you might have the gummy smile measurement in place and it's good, but then you might still need a few more millimeters sometimes to allow the restorative space that we need. And at this point so far, this has worked every time with careful analysis. You know, I think it's a good formula, and it's something that the doctors will understand when you talk to them and you're going over your case plan. Okay, so this is the actual result on this case, gummy smile. This is how we applied the formula and smile. Okay. This is another gummy smile here where it was a situation where we could not actually use a hybrid or, you know, a fixed hybrid that we're used to making, and we had to actually use a crown and bridge. We had to do the crown and bridge approach with the chrome natural guide, the scallop guide, and so we planned it, put implants in, and this is the provisional right before we went to the final appliance, which made a big difference in her smile. So we simply applied the formula for the hybrid. It didn't work, and so we're still working with this chrome natural, and we've worked out the biology on that. I think we're having success with it, and we have measurements for that we have not yet finalized. But you know, this is a case we used it on, and the result we got. So the guided smile process. Everything you've seen up to this point are things that should be done before the scans are taken. Before they should be. You're not going to get 100% cooperation with that, maybe less than 50 sometimes, but you know, this is what we suggest that doctors do before we continue with one of these cases for the best possible success that they can have. Now, as you do case by case with your customers, they will begin to learn this. It's painful and it's excruciating sometimes, but they do begin to learn it and start giving you what you need to get the case done without having to go back and forth a few times to get the information. So with that, that is the end. I will be happy to entertain any questions, as many as anybody has. So, fire away.